So my name is Dr. Bell. I was asked to give a lecture on my experiences at the Public Health Department. I really have only been at the Public Health Department for 18 months. So I kind of decided to turn this more into an explanation of certain training programs that residents and other physicians or even med students may not know about that may help if they choose to go into public health. So I titled the lecture Public Health Possibilities. The objectives are to define public or population health. We'll actually go through an intro to public health based mainly on public access CDC slides. We want to remember, and I want to remind participants that primary care providers in the private domain not only participate in public health, they provide the majority of public health in the United States. They just may not know it. And to review additional training opportunities in public health. And we'll start off by a definition of public health. This is where I need notes even to say his name. Charles Edward Amory Winslow. People don't name their kids like that anymore. He was a leading figure in the development of the study of public health. He is what we'd call a microbiologist today. He was a bacteriologist. He helped found the Yale Department of Public Health and was involved in water sanitation and sewage development. He defined public health as the science of art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And that public health aims to provide maximum benefit for the largest number of people. I'm more of a simple person. Maybe that's my public education in New Mexico. I think of population health and public health being similar. And essentially, it's the health of a population as opposed to an individual. Now, most of us are clinicians, and we have a skewed thought of healthcare and what health is. Can everybody see my arrow on my screen? Good.
Yes.
So it's worth noting that medical care is really a minority or has a lower impact on the population of a health of a population as opposed to our individual behaviors, our health behaviors, situated in the society and environment in which we live. So that if you have a sidewalk or park nearby in your environment and you choose to run or spend time outside, that may be a healthy behavior. Or if you live next to a smokestack, staying inside in that instance may be a healthy behavior relative to exposing yourself to the pollution. And if you had to define achievements within the US in the 1900s, here's a list of achievements provided by Merian Health, not the CDC. Vaccinations is clearly on top, and you'll see this in every slide on accomplishments. But motor vehicle safety, workplace safety, control of infectious disease, decrease in cardiovascular disease, food safety, safe drinking water, family planning, and recognition of tobacco as a health hazard. It's worth noting for clinicians that we really don't participate in motor vehicle safety. This is government policy, seat belts, airbags, speed limits, the production of vehicles that will compress on impact. Workplace safety. In the 17 and 1800s, environmental safety, workplace safety had a major impact on the disease of a population. As clinicians, we often don't see that because we're not on these workplace sites. But again, this is government regulation. Food safety and safe drinking water, again, government government regulation, environmental departments, providing more to the health of a public often than what clinical medicine does. Worldwide achievements, similar: vaccinations, prevention of control of infectious diseases such as HIV, TB, malaria, reduction of childhood mortality, reduction of motor vehicle deaths, safe water, and again, the recognition of tobacco as being associated with disease. Once again, you have motor vehicle deaths and safe water outside of the domain of individual clinicians contributing to the health of the public at a higher scale. And U.S. public health achievements since 2000, again, vaccinations. It stays on the list because we develop more vaccinations. We have COVID vaccinations, we have vaccinations now for Ebola, we have vaccinations for HPV. These vaccinations we did not have in the 1900s. Tobacco reduction again, occupational safety, cancer prevention. Now here, physicians start to play a role. Reduction of the risk factors associated with cardiovascular disease, such as hypertension and diabetes. Lead poisoning reduction, the removal of lead from gasoline and from paint, that's going to be a government policy. And unfortunately, the U.S. does have failures in public health. And I think if we remember back to the COVID pandemic, there was really inconsistent communication by government and public health officials within the United States. Part of that is a function of how our government works, and we'll talk about that in a second. There's also an opioid epidemic leading to deaths, and syphilis has kind of reemerged as a historic disease to a modern disease. Now, primary care contributes to public health maybe more than a public health physician does. All primary care physicians participate in public health, whether they know it or not. It's easier to see through screenings such as colorectal cancer screening or pap smears or mammograms. You screen a population, and by catching something early and more treatable, you're moving that individual from a high-risk population to a low-risk population. Often as physicians, we think we're treating an individual, but I would argue that we're treating a population. And I'll reinforce that maybe with the example of diabetes. If I take a diabetic, I start them on insulin and I reduce an A1C from 8 to 7, we'll say I'll prevent maybe 7 cases of retinopathy. I'm not sure if that's true. This is an example. I'm not going to be able to predict in the population with an A1C of 7 which of those individuals will go on to have retinopathy and which will not. I just know that fewer in that group will have retinopathy as compared with the population with an A1C of 8. On an individual basis, when you treat diabetes, you don't know who in your better control group is going to go on to have disease and who in your high-risk group isn't going to have disease. There will be people with an A1C of 10 that will never have a complication from their diabetes. It's just fewer of them exist compared to in the lower risk group. Sexually transmitted diseases. You can think that having a sexually transmitted disease is a failure of public health because we didn't prevent the spread of disease. But when they present to you and you treat it, you prevent the spread of that disease further. And most STDs are treated in primary care clinics. And this screen should highlight that. I'm just going to ask real quick, is my control bar in the way of the title? No, okay, good. So, for example, this was in New Mexico in 2022. For a full 44% of chlamydia cases were treated in primary care offices. 15% were treated in hospital settings, ERs, urgent cares. Only 11% of chlamydia treatment in New Mexico in 2022 was provided in STD clinics in the public health department. This is now true for gonococcus and syphilis as well. Historically, if I took chlamydia, the majority of chlamydia would have been treated in a primary care's office. Gonococcus would have got almost a half being treated in an STD clinic, half being treated in a private care clinic. And the majority of syphilis had been treated in STD clinics in the public health department. But as syphilis and gonococcus had become more prevalent, more and more primary care physicians have been treating them. And now, even with syphilis, most syphilis treatment is done by primary care physicians. Now, the public health system in the United States is a collaboration of government, clinicians, universities, and the media. So, for example, if I wanted to reduce tobacco, you might have a government policy targeting smoking on airplanes or in bars. Then you might have a media campaign advertising the risks of smoking. You might have clinicians telling their patients about the risk, offering them treatment, prescribed treatment to help them quit. And then you may have universities that come in and evaluate whether our policies or interventions are working in either the reduction of tobacco or the consequences of tobacco use, such as cancer. Now, part of the wonder of the United States, and it's sometimes a weakness of the United States, is the fact that we are a federalist society and we have layers of government. France or Spain or England may be more centralized, where the federal government has a lot of control over their country. But historically, the state governments ran the show well into the 1800s. If you see the film Killers of the Flower Moon, the FBI has just been created and they're looking for a case or a place where they have jurisdiction. And they're really having trouble defining what the jurisdiction of the federal government is. And one of their jurisdictions is to do criminal investigations on Indian reservations. So it was in public health. The majority of public health was run by the state and county governments for many years up until World War II. We also have the federal government now through the CDC and the NIH also working and helping us with public health. So that when you implement a policy, you have this layered approach. So if we take smoking again as an example, you might have a county that outlaws smoking in bars or a municipality. And a state could increase the tax on the cigarettes, making it more expensive for someone to purchase and maybe making it too expensive for them to afford. And then the federal government might ban it on trans-state travel in airplanes. And then they may do surveillance to see if who is smoking, where they're smoking, and then do some sort of evaluation to see if these policies are reducing tobacco. You know, I included this slide because it was part of the public domain from the CDC. Many clinicians will feel that they're treating individuals, whereas public health is more population focused. But I would say that the studies we apply to individuals usually are population studies of diabetics or populations of those with heart disease. So I think the individual focus is often overemphasized by clinicians or misunderstood. But clearly clinicians are worried about a patient coming in, figuring out the diagnosis of their pathology and providing treatment if available. And it's also worth noting that for historical purposes, the majority of the care in the United States is in the private domain of either hospitals, corporations, or private practitioners. It's not within government agencies such as the VA or the public health departments. And the last of my public health slides, I have this really just to highlight the need for evaluation. once you put a policy into place, let's say you determine that we need to do more colorectal cancer screenings to decrease colorectal deaths. You have evidence for it from universities or from medical schools. You implement it. You have to have some sort of evaluation to see if the policy is working. And then at the New Mexico Department of Health, I feel kind of bad because this slide is a disservice to the New Mexico Department of Health. The New Mexico Department of Health has many divisions, of which the Public Health Department is one. That's the division I am in. And that division offers some clinical services. But clinical services in the New Mexico Department of Health is a minority of what we do, okay? I'm ignoring epidemiology, injury prevention, the storage and maintaining of vital records, nutrition for women, infant, and children in childbearing years, health facility licensing, the managing of the state lab, licensing of emergency transport. But as clinicians, we're interested in clinical services. We provide tuberculosis treatment, STD screening and treatment, family planning, breast and cervical cancer screening for a defined uninsured population, hepatitis C treatment, pediatric vaccinations, pediatric specialty services. We provide essentially space for specialists from the UNN, from the University of New Mexico, to go to outlying areas and to provide subspecialists to the kids of New Mexico. We have a PrEP program, pre-exposure prophylaxis, to prevent HIV in men having sex with men primarily. I believe the New Mexico Department of Health provides about 25% of all PrEP services in New Mexico. We provide post-exposure prophylaxis with doxycycline to prevent STDs in men who have sex with men. We provide HIV services and refugee services, essentially screening refugees for lead toxicity, to make sure their vaccinations are up to date, and to screen them for TB. Now, I want to spend the bulk of our discussion on training opportunities for physicians who may want to go into public health. Now, by definition, some of you listening might be training in internal medicine or family medicine. So we may have missed the boat already for some of these trainings, and it should maybe be targeted more to medical students. Anybody training in family medicine, internal medicine, and pediatrics will have a good foundation of medical knowledge if they choose to go on to public health later in life. At least I hope that's true, because I'm an internist. But there are additional residency training programs that many med students don't even know about. One is public health and general preventive medicine, and the other is occupational and environmental medicine. Now, public health and general preventive medicine, if you get on the American Board of Preventive Medicine, they'll define their specialty thusly. Public health focuses on promoting health, preventing disease, and managing the health of communities and defined populations. These practitioners combine population-based public health skills with the knowledge of primary, secondary, and tertiary prevention-oriented clinical practice in a wide variety of settings. Typically, it's a 2-year residency. To enter the residency, you have to have completed your Step 3, your COMLEX 3 or USMLE 3, and you will need to have finished 1-year training in a residency program with direct patient care. Now, it can be a prelim internal medicine year, a prelim general surgery year, pediatrics, a transitional year, or if you enter a specialty such as family practice and you decide you don't like it after a year and you finish it, and if you pass your USMLE or COMLEX 3, you can become eligible to apply for this residency. A Master of Public Health is required to sit for the boards and to graduate. If you do not have it already, it's usually finished in your PGY2 year. Now, the emphasis on the study is going to be a little bit different. you study biostatistics and epidemiology, chronic and infectious disease surveillance and contact investigation. Your clinical medicine is more limited to tuberculosis, infectious disease, STDs, family planning, and addiction medicine. You also do preventive medicine, such as obesity, wellness, lifestyle clinics. You also cross-train in environmental and occupational health, which would include injury treatment and prevention. And likewise, you have to study health systems management and administration. Occupational medicine, on the other hand, focuses on the healthcare of workers, including the ability to perform work, the physical, chemical, biological, and social environments of the workplace, and the health outcomes of environmental exposures. Practitioners in this field address the promotion of health in the workplace and the prevention and management of occupational and environmental injury, illness, and disability. Again, you must have completed 1 year postgraduate medical education training in an accredited residency program. You must have completed the USMLE 3 or the COMLEX 3, and you must also have an MPH. The curriculum focuses on occupational and environmental medical clinics, regional consultant, fitness for duty, workers' compensation and disability, toxicology, environmental hazards, and work site visits. As physicians, sometimes we get needle sticks, either in clinic or in the emergency room, and we'll often be sent to an occupational clinic where they'll assess our risk to go on and have HIV or hepatitis B, and they may recommend prophylaxis. That's just one example of what someone might do in an occupational clinic. Most of us have heard about a Master of Public Health. Majority of people that hold a Master of Public Health are not physicians. But a physician can choose to get an MPH. The basics of an MPH is biostatistics, statistical methods that it applies to biology, some of the things we hated in med school, like bell curves, p-values, positive predictive values is a field of study necessary to the interpretation of data. Epidemiology is the study of distribution of disease in a population. Health Services Administration, workforce solutions, how did our system of medicine develop, the business aspect, the financial aspects of Health Services Administration, the environmental aspects of disease, and social and behavioral aspects of health. Now, an MPH is much more than that. I kind of simplified it. You have to go on to do 40 hours of graduate training in total. So you'll go on to do research, planning, policy, community organization, evaluation of policy and procedures, finance, budget, ethics. But if you want to cop out, similar to what I did, I felt kind of old relative to all the young people taking an MPH. I opted just for a public health certificate, which is really just the basics in epidemiology, biostats, Health Services Administration. And it's really, depending on the program or which university, it's 12 to 15 hours. So basically 4 to 5 classes in graduate work. I took it because COVID hit. We didn't have anywhere to go. We couldn't take vacation. So I took a class a semester from New Mexico State University online. And we'll go on to fellowships, some more well-known and some less well-known. We'll talk about infectious disease, addiction medicine, toxicology, STD fellowships, a certificate in tropical medicine, and we'll talk briefly about the Epidemic Intelligence Service. If you're an internist or you're a pediatrician and you want to go on and study infectious disease as a fellowship for 2 to 3 years, that's available to you. I'm not going to go over an ID fellowship, but I would think its contribution to public health would be evident. But perhaps some people aren't thinking about addiction medicine or toxicology, and I really want to focus on addiction medicine. I listed this as a subspecialty of public health and preventive medicine, and that's true, but many specialties can go into addiction medicine. And just to go over why it's important from a public health point of view, in 2021, there were 100,000 drug overdose deaths in the United States, most of which were from opioids. If you compare it to COVID deaths or deaths from strokes in the same year, you can see that overdose deaths are approaching deaths from strokes. Let me see if I can move my picture out of the way over here. You can see on this slide that opioid deaths was already accelerating in the United States in 2014, well before the COVID pandemic. And if you add in the COVID pandemic here in 2019, it just skyrocketed. The addiction medicine specialty, they did it correctly. You don't want to create barriers and say only this specialty can subspecialize. They said, we need anybody interested in addiction medicine, we need them to have access to this fellowship if they want it. So anesthesia, emergency room medicine, family medicine, internal medicine, OBGYN, pediatrics, preventative medicine, that should read preventive medicine, I'm sorry for the misspelling, and psychiatry. Psychiatry's had their own fellowship in addiction medicine for a long time, but really these other specialties, this is a relatively new in the last decade fellowship. It's 1 year, so it's not long after finishing your residency. It's more than opioid addiction. I mean, at the public health department, we work with buprenorphine and opioid addiction, but this is much more in depth. You deal with alcohol, methamphetamines, tobacco, as well as opioid addiction. You train in inpatient detoxification, withdrawal management. You work in residential treatment facilities, outpatient clinics. You learn policy, you advocate for policy changes, and you learn motivational change techniques. Toxicology. In theory, toxicology is a specialty of preventative medicine, but I could not find an example of the fellowship on the ACGME website. I did find examples of toxicology for emergency room medicine. And the closest one I found was in Tucson. It's a 2-year fellowship, and you train in poison control, venoms, toxins, chemical exposures. And this would make perfect sense for someone in the emergency room after someone ingests antifreeze or methanol, coming in to determine what type of acidosis they have, whether they're going to need dialysis, and when they should go to the ICU. But from a public health perspective, clearly a poison control center is needed, and toxicologists are needed as advisors. Now, hopefully, many of you have already heard of the specialties that I've mentioned, but I want to kind of throw in some things that might be even rarer. And so I've titled this Think Outside of the Box and not worry so much about what you can certify in or sit for a board in. So we're going to talk about EIS, an STD fellowship, tropical medicine, and then we'll talk briefly about a global health course that you can take in Tucson. Now, as a former residency director, one of my, I'm not going to say pet peeves, but one of the things that always bothered me is when medical students and residents would come to me and they say, I have an interest in global health. And then they become a radiologist and sit in a room, and then they look at scans, and they don't really enter family medicine or internal medicine or take the dive into global health. I would say if you're truly interested in global health, this would be a good avenue to pursue. The Epidemic Intelligence Service is at the CDC. It's a 2-year fellowship. If you are a physician, you must have completed a medical degree and you must have an active U.S. license to practice medicine. They prefer for you to have some public health experience and to have an MPH. It's encouraged, but it's not a requirement. And it's important to realize that you don't have to be a doctor to do this. You can be a vet, you can be a physician assistant, you can be a scientist, you can be a pharmacist, you can be a nurse. And each of these professions will have its own requirement to enter the EIS. The EIS has been around for a very long time, since 1951. I would note it predates the specialty of family medicine. It predates the specialty of emergency room medicine. It predates the specialty of rheumatology. It predates, I believe, the specialty of oncology. They were around for smallpox eradication. They were around to do surveillance at 3 different Ebola outbreaks. They were around to describe the presentations of opportunistic infections in a cluster, leading to the concern that a single virus might be the cause, such as HIV. They were, of course, around for COVID as well as the H1N1 pandemic. If you get an MPH, it's an academic situation. You're taking classes at a university. You do some field work. You may have a thesis. But the EIS is really clinical in nature, practical, and it's on-the-job training. And you learn to investigate outbreaks, to conduct epidemiologic research, surveillance. You learn to analyze data. You learn to communicate with media and other health departments. You learn how to help other health departments, to provide them counsel, and you learn how to do academic presentations. And if you are truly interested in doing global health, you will travel with boots on the ground if you go into the EIS. And I'll try to give an example at the end. This is just a brochure on the requirements and how to apply. On most of these slides, I've included the links to their websites. So I started off, I got interested in medicine in the military when I was stationed in Guatemala, but I got sidetracked. I went to the University of New Mexico and I decided to go into internal medicine because I didn't know if I wanted to subspecialize or not. And I ended up not subspecializing. Then I became a hospitalist. And then as hospital medicine became more defined and a little constraining, as you started spending more time in front of a computer screens and people started to tell me to do all my discharges by a certain time, I transferred to outpatient medicine. And I got involved in public health as my residents. I developed a rotation for my residents to increase their access to women's health because I didn't think their training at the time was sufficient where we were training them. And it kind of exploded and they got exposed to different aspects of public health. And then so I went over and shadowed them. And then I realized when I was shadowing them that I'd gotten trapped a little bit in this kind of corporate mentality of medicine. So for me, it was a way out. If I had to retrain now, and this is, of course, knowing that I don't have debt, which was not true when I got out of medical school, I would probably become a family practitioner, and then I would probably pursue a certificate of knowledge in clinical tropical medicine and traveler's health. As opposed to an MPH, again, this is going to be much more clinically oriented. It's been around a long time. The American Society of Tropical Medicine and Hygiene was founded in 1903, and it's dedicated to the reduction of tropical infectious diseases and improving global health. There is a certificate. The requirement to sit for the exam includes a completion of an approved diploma course and then 2 months of overseas or relevant domestic experience. So I trained at Baylor College of Medicine. After leaving, they developed the Baylor College of Medicine School of Tropical Medicine. And they essentially have 4 modules and a lab. They're seminars. You can think of a module being 2 to 3 weeks, 8 to 5, Monday through Friday. And in module 1, you study bacteria and viruses. In module 2, you study parasites and fungi. In module 3, you study tropical medicine and practice. In module 4, and I highlighted this to show redundancy, this training as compared to an MPH. You study epidemiology, as well as biostats and health service administration. The lab, you get in-person, hands-on laboratory sessions in diagnosing viral infections, bacterial infections, parasites in a lab. I may have misspelled epidemiology there, and I apologize. You get on the Baylor College of Medicine website, they define tropical medicine as the study of the world's major tropical diseases and related conditions, including neglected tropical diseases such as hookworm, schistosomiasis, Chagas, leishmaniasis. But they also study malnutrition and hygiene, HIV, AIDS, and tuberculosis, things that we see commonly in a public health department. It's 3 to 4 months. You do not have to be a physician. Nurses can do it, physician assistants, nurse practitioners. But unlike some traditional fellowships, you pay. This is like going to get an MPH. You pay, and it's about $9,000. This one is with Baylor College of Medicine. The other example I give is the Alexander von Humboldt Tropical Medicine Institute in Lima, Peru. I'd probably choose this one. The diploma course is the Gorgas Diploma Course in Clinical Tropical Medicine. It's 9 weeks. It's in Lima, Peru, and it's taught in English. It's named after a United States general that helped eliminate malaria and yellow fever in Panama prior to the building of the Panama Canal. It's targeted toward physicians, nurses, physician assistants, and public health professionals. It's a collaboration between the University of Alabama at Birmingham and the Alexander von Humboldt Tropical Medicine Institute in Lima, Peru. You do get CME if you're a physician, and again, it's about $9,000. Slightly different curriculum than Baylor. You study anthrax, brucellosis, leptospirosis, leprosy, rabies, leishmaniasis, Chagas, but you study HIV, viral hepatitis, biostats, epidemiology, TB, and STDs, clearly relevant to any public health department within the United States. I highlighted cyclospora just to remind myself that even though I'm not treating enteric diseases here, we have a nurse epidemiologist that has to track most enteric diseases and then coordinate it with the private community, the treatment of Salmonella, Campylobacter, Cyclospora, and Cryptosporidium. Now, the American Society of Tropical Medicine puts out a list. I believe they update it every 2 years of acceptable countries where you can go for your tropical medicine experience. Sorry, that font is a little small. And then once you have your diploma course and your 2 months experience, you can sit for an exam that's offered every 2 years. And the exam topics, again, cover epidemiology, biostats, nutrition, sanitation, TB, STDs, and hepatitis C, amongst other things. Clearly, a good preparation and foundation to enter a public health career in the United States. There are also academic STD fellowships. The University of California at San Francisco and the California Department of Health partner to provide an STD fellowship. It's 1 to 2 years. Salary is based on your PGY level. You learn STD control and response. You do participate in research, and you are responsible for academic presentations. And I want to give a shout out to Wyatt Hanford, who holds an MPH. He's the current fellow in this program, and he gave an excellent lecture to the New Mexico Department of Health on mycoplasma genitalium. And then I'm going to end with a program at the University of Arizona College of Medicine in Tucson. If you don't have, you don't have time for that type of training in MPH, or you don't want to spend $9,000 and spend 3 months learning or obtaining a certificate in tropical medicine. The University of Arizona offers a 3-week global health, public health course, specifically designed to prepare you to work in low and middle income countries. And they concentrate on women's health, tropical infections, disaster management, refugee and migrant care, border health, and they provide an introduction to public health and epidemiology. Now, I limited myself to programs around the Southwest, typically with the exception of the one in Alabama and Peru. But if you had further interest and you wanted to check out the World Health Organization, they have an internship program and employments, and here is the link if you choose to follow that. And then I wanted to give examples so that it wasn't seen as something in a vacuum or unattainable. At the New Mexico Department of Health, we have Christopher Novak, who has an MPH. His specialty is preventive medicine and public health. He is currently the medical director for the public health division in the New Mexico Department of Health. He interrupted me and brought me lunch. I was supposed to be meeting with him instead of giving this presentation. Christine Ross, she also holds an MPH. Her specialty is family medicine. She is a graduate of the EIS and a former and future employee for the CDC. Excuse me. A former and future employee of the CDC. She was stationed in Africa at the time of COVID. She came to New Mexico to be our epidemiologist. She became the regional health officer for the Northeast region, and she's just accepted a tour with the CDC, and she'll be stationed in Thailand. Laura Parajon, she's also a family medicine physician from the University of New Mexico. She holds an MPH as well. She spent 2 decades in Nicaragua training community health workers to improve child mortality. And she's accepted a position with the CDC as Deputy Director for Chronic Disease Prevention. Those that pivot. Miranda Durham is a family physician. She's currently the Chief Medical Officer for the New Mexico Department of Health. She's the former Regional Health Officer out of Albuquerque. She has a background in Native American primary care. Savannah Bustos has a specialty in family medicine. She's currently the Regional Health Officer for the Northwest region of the New Mexico Department of Health, and she has a background in community health care. My name is Michael Bell. I've already told you I'm an internist. I'm the current regional health officer out of Las Cruces, New Mexico. And I said we pivoted in that we really didn't do anything extra. We just came to the job and adapted. We have Dr. Marcos Burgos, who's an infectious disease physician who works at the VA in Albuquerque, but contracts with the New Mexico Department of Health to provide consultation for all of our TB cases. And outside examples, we have Wyatt Hanfit that I mentioned previously, who holds an MPH. He's the current STD fellow at the University of California, San Francisco, and the California Department of Health. And then we have Ronald Poost, who holds a certificate in tropical medicine. He's currently retired from the University of Arizona in Tucson, but he was the founder of the Global Health intensive course that I showed earlier. He has extensive clinical work in Africa, as well as the Navajo Nation while he worked at the CDC. Graduating from Memorial Medical Center Family Practice, we have Jamie Winan, who I spoke to briefly. He currently works in Tucson, Arizona. He graduated from the New Mexico Family Medicine Residency Program at NMC, but he also completed an addiction medicine fellowship at the University of Arizona, and he provides care for addiction, HIV services, and transgender care at a community health center. And then my personal favorite physician, Dr. Diane Cruz, is a true general practitioner. And I think I still have the bias that we should kind of return to this model. In New Mexico, you can no longer do this coming out of training. You have to have 2 years postgraduate training. But she's a general practitioner with simply 1 year training after medical school in what I used to call a rotating internship, where she did 3 months of pediatrics, 3 months of internal medicine, 3 months of OBGYN, and 3 months surgery. She spent 30 years at the Student Health Department at New Mexico State University with family planning, treating latent tuberculosis infection, treating STDs, providing mental health, and treating addiction medicine. And I want to say on a personal note, she's the most adaptable physician I know. She's more adaptable than me. And that's everything I have. I'm open for any questions, and I hope I did not go over my time, or I'm not too under my time.
Hi, Dr. Bell. Can you hear me?
I can.
Hi, I'm one of the resident PGY3 in Family Medicine Alamogordo program.
Yes.
And I am right now interested in hospitalist job, and also looking at your experience on hospitalist and primary care and everything. Are there any fellowship or anything that I can do while I'm working?
While you're working, I think it's going to be difficult. You mean as a hospitalist?
Yeah, because I'll be working at 7 on, 7 off, and I'm interested right now. I'm joining hospitalist right after my residency, so I don't know whether I want to do hospitalist all my life. But I wanted to be closer to my family. That's why I signed this job. And I have my background. I'm an international medical graduate. I did medicine in Nepal, and from Nepal I came to US, and I was doing research at University of Louisville, Kentucky. There I started MPS, but in the middle of my MPS I massed here in residency, and I started residency. So I did like 1 year of I did like almost 50% of my MPS in public health, in epidemiology and biostatistics. And I want to continue that, but because of my visa, I have to join some job. I couldn't do this as a student because I'm on J1 visa. So is there any fellowship that I can do online, or is there anything that is related to public health?
I think what I would recommend is this. First of all, as a hospitalist, my favorite boss that I had was from Nepal, Dr. Sering Sherpa. She's a hospitalist in Silver City, New Mexico. You know, you don't want to violate your visa requirements. I think the most important thing is completing your visa requirements and eventually getting your green card. And I think working as a hospitalist is a good way to start. And I think if you wanted to, you could slowly over time in an online program finish your MPH. I think that's very doable. After you finished your visa, if you wanted to do more training beyond the MPH, that preventive medicine and public health becomes a 1-year fellowship for those who are board certified in family practice, internal medicine, or pediatrics, and already have an MPH. So you could finish your MPH on an online program while you're a hospitalist. And once your visa requirements are fulfilled, if you wanted out of hospital medicine, you could also, if you wanted to, do a year fellowship in preventive medicine, public health, or even a year fellowship in addiction medicine.
That sounds good. Yeah. Thank you so much.
All right, we have time for about one more question. Any other questions?
Dr. Bell, I was going to ask you, the fellowship that you did in Baylor College, is that online or is that in person? The one that you discussed about 4 modules?
So it used to be only one module was online and the rest were in person. With COVID, I believe all of those modules are now online and just the lab is in person. But all you could just simply log on to the Baylor College of Medicine School of Tropical Medicine, and you can just look up the requirements.
Yeah, thank you. Thank you so much for a wonderful presentation, Dr. Bell.
Thank you. I hope it wasn't too boring. I always get worried about that.
No, it was not. It was not.
Any other questions? I'll see you all later then. Thank you so very much.
Dr. Bell, thank you very much for joining us today and for the great presentation. Everyone, thank you very much for attending and have a great rest of your day.